Okay, good morning, everybody. Thank you for joining our first research webinar. Very happy to see so many of you joining us this morning. My name's Esther. I'm the Chief Executive of Leeds Hospitals Charity. For those of you who haven't already seen, we've changed our name. We were Leeds Cares, but following feedback, we've changed our name to better reflect the work that we do. An important part of the work we do as a charity is fund research within the hospital. Last year, we actually contributed 1.2 million towards research, and that was thanks to money that we received from people like yourselves who've made donations, and also from gifts in wills. So we've got some really amazing speakers lined up for you today. And you're going to learn a little bit more about how the money you've donated and other people have donated is making a real difference to patients who are benefiting from the research that's being done. And I just want to let you know that the webinar is being recorded, but it's only the speakers that are visible. So it won't be, you'll basically be anonymous unless you choose to speak. So the webinar is being recorded from now. It also means then that if there's anyone you know who hasn't been able to make it this morning, then we'll be able to share the link with them so they can watch it back another time. So the first person I'm going to introduce this morning is Chris Herbert. So thank you very much for joining us, Chris.
Thank you. Good morning, Esther, and good morning, everybody. It's lovely to be here this morning. And I just wanted to kick things off a little bit this morning and just outline why Leeds is such a great place to do research. You'll hear a lot of real-life examples of the breadth of research going on in the Trust later as we work through the next hour. But I just really wanted to set the scene and put things in context for what you want to hear. You can click to the next slide, please. This infographic, for me, really says everything about Leeds Teaching Hospitals and its breadth and scale of services. 1.15 million outpatient visits a year, 106,000 day case patients a year, 1.5 million patients every year, 17,000 staff, 10,000 babies born, 2,000 beds. Nowhere else in the country has the scale of services that Leeds Teaching Hospitals has. And that gives us a really unique foundation to run a wide range of research across both adult and children's services and across the interface where adults and children's services make. And it's really well evidenced that hospitals actively engaged in research have better patient outcomes and a more positive patient experience. So research is good for care of patients even where they're not involved in research. And underpinning our role as an NHS teaching hospitals, we work with partners right across the health and care system to plan, train and develop people to make sure they've got the right skills to deliver research, both now and in the future. Next slide, please. So research and innovation in the Trust is underpinned by the central team that actually provides a managed service to help champion research, support delivery of research, and to really look ahead, working with researchers to look at future infrastructure, skills needs, and help plan where we're going with research. We really want to make sure that everyone in the Trust has an opportunity to participate in research and look at where we're going to go in the future. For example, advanced therapy, cell and gene therapies, which use living cells, viruses. We've recently been put some investment in there to create some knowledge and skills in both pharmacy, research delivery teams and investigators, so we can build new trials in really cutting edge ways going forwards. And the work of the hospital charity really underpins what we want to do in terms of delivering this managed service that is supporting the delivery of research and the development of research in the organisation as well. It helps pump prime new functions within the research and innovation team, and I'll talk a little about an example of that in a couple of minutes. It helps support infrastructure. Last year, we opened a brand new clinical research facility in the Bexley wing for carrying out early stage clinical trials. That would not have been possible, but without some of the ongoing support we've had around that from Leeds Cares. And of course, Leeds Cares also supports a wide range of projects and fellowships, which helps people get projects going, get initial data done, and helps them then be competitive for other external funding. So then allowing them to pull in other money to continue their work funded externally by others. Go to the next slide, please. So we're really ambitious. We have just launched a new strategy for the next 5 years for how we're going to develop and deliver research in the trust. And really our big headline key performance indicator is that over these next 5 years to 2025, we want to involve over 100,000 participants in research studies in the trust. And that's a huge number. That's a real stretch for us. That is over 20,000 people a year. And the impact of COVID pandemic is going to make that job slightly more difficult, because we're a little bit behind this year in terms of the challenges that has presented to us. But we also want to grow our portfolio of research studies to something, we have about 900 open at any one time at the moment. We want to grow that to about 1,100, 1,200 studies open at any one time by 2025. And a big part of this is going to be about making research visible both across the trust and across the city as well. So a lot of proactive patient and public involvement, working with Leeds Cares, spreading the message, and actually making research visible, really making the visible across the trust, making staff aware of what's going on, making staff aware of how they can be involved, and making patients aware of how they can be involved in research as they come into the organisation. And I genuinely believe that Leeds ought to be the go-to place for the country for anyone wanting to do medical research, whether that's partnering with the trust to deliver a project, or actually coming and basing themselves in Leeds to be an academic, to be a clinician, to be able to deliver research and be part of the ecosystem here. Next slide, please. We, of course, can't do any of this without partners. I can't do my job without other people working. And so our partnerships with patients, academia and industry really underpin what we do. We have a really strong partnership with the University of Leeds. We have some great partnerships with other local universities. And of course, we work nationally as well with a wide range of other university partners as well, bringing in expertise from around the country to support research and help deliver research within the trust. A really important aspect of the work we do as well is around patient and public involvement. This is an opportunity for patients, members of the public, to both help research, help shape research programs, to help support and oversee some of the delivery, and also support engaging people to actually participate in research, being advocates, champions for research as well. And that's a really important part of the work we're doing, and something we're looking at growing. Next slide, please. And of course, it is not just about research and well-being and patient outcomes. I actually believe that there is a wider role for research and innovation in the trust and in the city as well, actually looking at how we support job creation and economic development, and then improving wealth and health outcomes through improving wealth as well. So one of the programs we're doing now, and what we're building with actually some initial pump priming support from Leeds Cares for a business development and innovation manager, is to really start embedding systematic support for innovation in the trust, and to go out and build proactively seek collaborations with businesses and other partners from across the world to pull the best technologies, the best innovations into Leeds for patient care, and to co-develop those with some of those companies. Examples of that is with some work we're doing with our radiology colleagues around artificial intelligence, and how that can be used more routinely in clinical service. We've got some really interesting partnerships working up there. But we really want to also get more into staff as well. Where have staff got ideas? How do we help them staff develop ideas? How do we make sure they can be more entrepreneurial, get training in that way as well, and really develop the culture of innovation in the trust as well. The new hospital build is giving us some fantastic opportunities. We can really tech enable the new hospitals as they're being built, and pull in some really high quality tech there. But those new hospitals also free up some estate on the Leeds General Infirmary site. So this year we will be opening up what we're going to call a pop-up innovation hub on that site, to seed the future developments on the estate. And that will allow some businesses to come in, base themselves within hospital infrastructure, have a desk, and actually be able to more proactively engage with clinicians, being together on things, and really helping pump those collaborations and make things work, but give a real focus as well for innovation activity going forwards. And of course, working with the local enterprise partnership and others in the city as well, to be really at the heart of a collaborative citywide infrastructure to promote economic growth and job creation in the city and in the region. So next slide, please. I just wanted to finish off and mention what the impact of the last 10 months have been and COVID-19. And whilst it has been a phenomenally challenging and difficult time, and something where we have been having to reinvent almost on a weekly basis what we're doing and how we work with researchers to make sure we've got the right portfolios open and things like that. COVID-19 has brought research to the fore like never before. Both from a staff engagement and a public engagement perspective. Staff engagement, we've had regular bulletins going out internally, and people have been really engaged reading what's been going on with research, and we've seen a real groundswell of interest, and we now need to build and continue that momentum. Public engagement, again, press releases, we've had pieces on Look North about vaccine studies, and other work we've been doing, and that's had a real impact. And we can see some metrics that we've been recording about people volunteering for vaccine trials, just about what the impact of that has had locally versus the rest of the country. And we've done, there's been an awesome amount of work, and we've really engaged people here and seen that flow through and people signing up for things through COVID, which has been great to see. We've had a huge impact on non-COVID research. We had to stop all that in March as other clinical services stopped, and these have had to be gradually restarted in line with clinical services, but we now have the full portfolio of research available. But COVID-19 locally has been a challenge, but I would call it 10 months of achievement. We had our first patient recruited into research within less than 7 days after there was the first COVID inpatient last March in Leeds. We've been setting up studies really rapidly. We've had UK and global first patients recruited into studies. That's a challenge to do even in normal times. So doing that for pandemic-based studies has been a huge achievement by the team. And I mentioned a trial on a vaccine we did in the autumn, and we were the UK top recruiter in that. We recruited 806 patients in a 4-week period in a sports hall on the University of Leeds site. A huge undertaking and a huge piece of work that got pulled together really, really quickly in response to things. So I want to finish there and actually now pass on to others to tell the real story of what's going on. And first, what we want to do is present a patient story, a video, Jack, a patient in the paediatric CRF. So Andrew, if you will, please.
Hello, my name's Martin, and I'm a research nurse here at the Children's Hospital in Leeds. We are currently standing in the clinical research facility, which is a 6-bedded facility which cares for children undergoing clinical trials here in Leeds. It gives them access to specialised treatment and clinical trials that not only improves outcomes, improves their quality of life and their quantity of life. This has come about purely and simply to the generosity of a family that left a gift in their will. We're incredibly grateful for people's kind donations, because without a shadow of doubt, we know, because we see this, it changes and improves people's lives on a daily basis.
Hi, my name's Claire. My son Jack was diagnosed at the age of 4 with Duchenne muscular dystrophy. This is a progressive, life-limiting, muscle-wasting disease. At the moment, as things are standing, Jack will go into a wheelchair, and then he will lose the use of his arms, and he'll have problems with his heart, his breathing, the current life. The current life expectancy is around 25, and we're just hoping that we can stop this, or at least slow it down until the cure has been found. Jack comes to the research facility once every 3 months. He does assessments, he walks upstairs, has his bloods done. For Jack to be given the opportunity to be part of research is absolutely fantastic for us, for Jack, for all the boys with Duchenne. Knowing that somebody's left some money in the will to help boys and girls like my Jack is just fantastic. I can't tell you how much that means to us as a family. If I met that person in the street, I'd say thank you and I'd give them a big hug.
My name's David Sebag-Montefiore. Thank you very much for the opportunity to speak to you today. It's great to see so many people on the call. I'm the Audrey and Stanley Burton Professor of Clinical Oncology. That name reflects the support of philanthropy in radiotherapy research, for which I'm extremely grateful, because I wouldn't be speaking to you today without that. I'm also director of the Leeds Cancer Research UK Centre of Excellence for Radiotherapy Research, which I'll come to in a minute. I also have a broader role as clinical director for the new Leeds Cancer Research Centre. So in the time today, really what I want to do is give you an overview of some of the really exciting areas in radiotherapy research. So what we're aiming to achieve is the best treatment and the best outcomes for our patients. And as a regional radiotherapy centre, we have a large patient base of 7,000 patients per year. We give nearly 90,000 radiotherapy treatments during that time. And Chris mentioned some of the challenges around COVID earlier, but radiotherapy is a service that has really managed to maintain very impressively through great teamwork its treatment for cancer patients through COVID. And for those of you not familiar with radiotherapy, 50% of all cancer patients will receive radiotherapy as part of their treatment at some point. And 40% of patients cured of cancer receive radiotherapy either as a sole or part of their curative treatment. So it plays a critical role in curing cancer. I'm delighted to be speaking to you today because we have undergone transformative change. So in 2008, when it rained, the roof leaked, my secretary had to move my computer, we had outdated equipment, we had no research activity. Today in Leeds Cancer Centre, we're an internationally leading UK centre. We have state-of-the-art radiotherapy equipment. We have world-leading radiotherapy research. And this has come about through partnership, through Leeds Teaching Hospitals Trust, the university, research funders, the NHS, but this really important part of the jigsaw of Leeds Hospitals Charity and philanthropic support, which really makes a huge difference to allow us to really move forward and trailblaze our research in Leeds. I wanted to highlight the really valuable importance of charitable funding, what I'm calling the multiplier effect. So the little seed in the top left panel growing substantially and starting that process to allow us to grow more research activity and become more effective and have more influence globally. So investments in people, such as research radiographers, clinical time, but also particularly in equipment, which I'll come to in a minute. And with a £225,000 investment per year since 2012, I think you can see a very dramatic impact in the number of research publications per year, which were just under 150 radiotherapy research publications in 2020, and a dramatic improvement in our ability to attract major grant funding to allow us to employ staff and do the research that we really want to do. So I'm just going to give you two examples of that. This is the first. This is something that we are world leading, and we are using radiotherapy as an opportunity to replace major surgery and avoid a colostomy bag for rectal cancer. This clinical trial was published only a month ago, and patients agreed to be randomized to either receive major surgery or an approach to avoid major surgery altogether, where they had a 1-week course of radiotherapy, very specifically targeted, with very local keyhole surgery to the tumor itself only. And impressively, only 30% of patients ultimately required major surgery. So patients kept their rectum and they kept good bowel function. They did not need a colostomy in 70% of cases. And the panel on the right shows a couple of graphs which demonstrate a measure of quality of life for the two treatment approaches. And the higher the level on the scale, the better the quality of life and the better the role functioning. And you can see that the green line, which is the approach to avoid major surgery, was associated with significant improvements in quality of life and role functioning compared with major surgery. So this is an area we're taking forward and we're doing a lot of work on. The second is a really exciting approach where we have excellence in technology and equipment to give short, 1-week precise radiotherapy treatments that can improve patient outcomes and patient cure rates. So this is known as SABRE, stands for stereotactic ablative radiotherapy. And it uses state-of-the-art engineering, computing, and radiotherapy to achieve highly targeted, highly focused, low side effect treatment, which we can give as an outpatient, particularly important in the COVID setting and beyond, over 1 week, a very short course of treatment. And in early stage lung cancer, we're seeing very, very similar outcomes to major surgery. And in fact, during the COVID pandemic, we've seen a significant increase in referrals for patients who otherwise would have had surgery to have radiotherapy and this very effective treatment. Through investment, we have grown a reputation as being a world-leading centre for this. We're the only centre in the north of England that was commissioned by NHS England to evaluate new approaches in the pelvis, in the abdomen to a site of spread, in the spine and to the liver. And the clinical trials are now beginning to show a very strong signal that when we give radiotherapy using this approach to 3 or less areas of cancer spread, we're seeing a strong signal that we're improving the overall survival of patients with local radiotherapy treatment, which is a revolutionary approach and really exciting for the future. So the investment from Leeds Cares and now the Leeds Hospitals Charity and philanthropy allowed us to grow to ultimately achieve a major landmark last year when we were awarded major funding by Cancer Research UK, recognised as a Centre of Excellence for Radiotherapy Research with a £3.5 million investment to allow us to move our research forward over the next 5 years. On the left-hand side, there are just a few members of the large team that made that application and that funding a great success. We are part of a very limited and esteemed network of excellence within the UK, which we are collaborating. And to give you some insights into what we're doing in the next 5 years, these approaches are to improve patient outcomes. So to personalize and give precise radiotherapy for less side effects and higher cure rates, to give re-irradiation, so safely give a second course of radiotherapy to improve outcomes for patients, and to combine radiotherapy with novel therapies, new treatments to make the radiotherapy more effective. We're doing this in a range of different cancers, and we're achieving this through approaches of imaging, data, and artificial intelligence. A key contribution, and this would not have been possible without your support, was the MR SIM appeal. So this is the MR scanner that will be installed in the radiotherapy department later this year. This is the quality of the picture we get at the moment with a standard scanner. This is the outstanding quality we get with an MRI scanner. And what that will allow us to achieve is better targeting, reduce side effects, and improve cancer cure. And I'm very grateful. I've seen there are a number of people on this call who've actually made a huge difference to our fundraising, for which I'm extremely grateful. So in the short time, I really wanted to summarize that your support makes a massive difference, and to say a huge thank you for your support. As I said at the beginning, I would not be speaking to you today, and my team would not be actually achieving what we're achieving without your support. We are now delivering world-leading radiotherapy research. With your help, we can do more, and we're passionate about the best treatments and the best outcomes for our patients. So I'm happy to take any very quick questions. Unfortunately, I'm going to have to leave the call a little bit before we get to the final discussion session. I'm not sure if anyone wants to put anything into the chat or ask a question, but otherwise, if not, I'd be very happy to hand over to others.
Good morning and Happy New Year, and congratulations on everything that you're achieving within the centre. What else could be done? Obviously, you've had an incredible last 18 months on this funding raise and building the team, but what would you like more from Leeds Hospitals now? So
good morning, Heather, and thank you for your support over the years, for which I'm extremely grateful. Wow. It's a whole range of fundraising opportunities here. I think it's very clear that there are certain aspects of research that research funders and the NHS will not fund. So the MR simulator that I described is a good example. If I gave you a long-term major ambition, I'm going to just put up a slide to actually answer your question. The next big step in the long term is this outstanding piece of machinery called the MR-Linac. This is only installed in the Royal Marsden and in Manchester. It's state-of-the-art equipment that actually combines an MRI scanner and a radiotherapy machine working at the same time, and for us to be able to track the tumor during treatment and give the most precise treatment. So for a long-term ambition, for a big ticket success, the MR-Linac would be a very major target for us in the long term, but actually to seed fund opportunities to allow us to have research active staff and to also provide some of the resources we need. We can do this at different scales according to the level of fundraising. So I'd love to do a more detailed presentation, but I hope that gives you just a little bit of an answer to your question.
Absolutely. And no, that Linac is a goal we've all got to try and achieve, isn't it, really? But here goes. Let's make 2021 that year that we can do it. So thank you anyway, David.
Thank you.
Good morning. I'm Shivanti Homer-Vanniasinkam, consultant vascular surgeon at Leeds General Infirmary. I also hold additional appointments as the Professor of Engineering and Surgery at University College London and the Professor of Surgery at the University of Warwick. Next slide, please. As I said, I work at LGI, and I've had a close collaboration with the University of Leeds since my appointment in 1995. Next slide. And it was a particular privilege to be appointed to Leeds as a surgeon, because of course we know that Leeds has been the home of great surgery for very many years, being the home of the undisputed father of British surgery, Lord Berkeley Moynihan. And you can see there him enunciating the attributes of a surgeon, and his biographer mentioning a particular trait of surgeons, some of us, of course, being the exceptions to that rule. Next slide. Ever since I came as a trainee to Leeds, I embraced the principles of translational research long before the term translational research come into being, because it was my complete belief that unless clinicians embraced science and worked alongside our academic colleagues in the universities, we would not really be able to take some of the amazing discoveries in the laboratories through to clinical fruition. This was a paper produced over almost 20 years ago. And I think it is really important and behooves us as clinical academics to engage in every aspect in this chain of scientific discovery. Next slide. The reason I say this is not because we produce the solutions, but it is important that we engage in asking the right questions so that we can work creatively with our academic colleagues in the universities and in industry to provide the right solutions. Next slide. Research is of utmost importance to our patients and to the public. This was a survey conducted some years ago, and you can see the overwhelming response of the public when they were asked whether it was important that the NHS carried out research and how important it was to them to have new treatments provided by healthcare professionals. And I think you've just heard Leeds produces some of the best research which translates into effective therapies for our patients. Next slide, please. Next slide, please. So I'll spend a few minutes talking about vascular research, education and training that has taken place in Leeds since I was a consultant here some years ago. Next slide. I think no one will argue with the fact that science is one of the greatest human endeavors. And particularly in the last 10 months, we have seen that if not for these amazing discoveries in science, we would not have the glimmer of hope we have today in the midst of this terrible global crisis. Next slide, please. Over the years, I've worked with a number of colleagues in the University of Leeds, but I mentioned two of them here in the interest of time, Professor Eileen Ingham, an amazing immunologist, and Professor Vas Ponnambalam, who is an exceptionally gifted vascular cell biologist. Next slide. With Eileen and John Fisher, I was very fortunate to be able to work on the now patented technological approach to decellularize natural scaffolds. Next slide, please. And it was Eileen's contribution in the immunology field that allowed us to completely decellularize these and yet have an effective biological natural scaffold that we could take through to clinical use. Next slide, please. So this decellularized protocol for tissues has now gone all the way from concept through to clinical trial and clinical application. On the left, you can see a decellularized pericardium, which I worked with Eileen, and we got a CE mark for this product, which is called a D-cell vascular patch, which can be used in vascular surgery. The decellularized skin is now part of a multi-center trial for diabetic foot ulcer patients, the largest diabetic foot ulcer multi-center trial, which is run with the PI being my former research fellow, now colleague, Mr. David Russell. And the decellularized skin is part of that large clinical trial. Next slide, please. We have also done a lot of work in vascular biology, and I'll just highlight a few of these. On the top left is Gary Cuthbert, our most recent MD graduate. A number of our research fellows, surgical registrars have gone on to do higher degrees at the University of Leeds. One aspect that we've been looking at is the particular receptor for the uptake of fats from the blood, which is the LOX1 receptor. And we have shown that we can inhibit the receptor so that we can have a positive influence in the pathogenesis of atherosclerosis. This work has now been extended. Next slide, please. And a new research fellow who joined us last year from the University in Oman will work on the expression and purification of these, of a specific protein called an affimer, for which Leeds is a leading university. And we will look at the effect of these affimers to try and block the uptake of lipids so that we can have a beneficial effect on atherosclerosis. In the middle of the slide, you can see a longitudinal cartoon of a blood vessel, a normal artery, and a diseased artery. And when the fatty streaks develop into full-fledged atherosclerotic plaques, they result in, and the atherothrombosis, these result in a stroke, a heart attack, or a major lower limb amputation. And it is this process that we hope to affect by working with Dr. Ponnambalam and the group in terms of using specific affimers to block the uptake of lipid particles onto the vessel wall. Next slide, please. We've also been working very hard in terms of vascular surgical education and training of our registrars and the students. Next slide, please. In 2 months' time, we will hold the first Leeds complex aortic course, and this would be, I'll be working with, be fronted by my colleague, Mrs. Monica Mathke, along with Mr. Gabriele Maritati, who trained with us all those years ago and is now a leading aortic surgeon in Europe. He's based in Italy. He will join the faculty, and we will hold this hands-on course in association with the Department of Anatomy at Leeds Medical School. Next slide. Along with Mrs. Rosie Darwood, also another colleague of mine in vascular surgery, we are looking for support to hold the first Yorkshire Human Factors in Surgery conference. Many of us know that improving the non-technical skills has a direct effect on improving the operative skills of a surgeon. And so we believe that we can hold a really meaningful conference here in Leeds, inviting guest speakers, nationally recognized guest speakers, and promote our center as a center where we can have these courses and conferences in the future. Next slide, please. A great ambition that we have set ourselves here in Leeds is to establish a Leeds Vascular Institute surgical simulation training suite. Here I'm working with my colleague, Mr. Tim Stansfield, who is also supported by the Ministry of Defence. As many of you will know, the vascular unit is only the second in the country, apart from London, to also be the receiving specialty for major trauma. So with my research fellow, Hala Ahmed, and supported by our management team here, you see Daniel Hodgson, our vascular business manager, we are aiming to set up a high-class surgical simulation training suite. The last year has had a very adverse impact on the operative skills of many of our trainees. And so this has highlighted to us the importance of setting up a simulation suite where some of these problems can be addressed in a meaningful manner. Next slide. We already have some rudimentary training kits. As you can see there, we have an aortic box trainer, which Professor Julian Scott has developed, a lower limb distal anastomosis kit, but we need to improve these. Next slide. So what we would really wish to do is to have much more higher fidelity simulators with a dynamic flow circuit that can be introduced. And I will be working with my engineering colleagues both here and in London to develop this with improved lighting, better ergonomic work surfaces where this can be carried out. And we were extremely delighted to hear just a few days ago that a dedicated room has been given to us on the infirmary site, which we will then use to develop the Leeds vascular surgical simulation unit. Next slide, please. In all these achievements over the years, we have a number of people to thank, but in particular, I'd like to thank the generous and continued support of the hospital's charity. They supported my own MD many years ago, and several of my research fellows over the years, many of whom have gone on to independent practice and some of them to independent chairs of surgery. So it is, if not for the huge support that we have from the hospital charity, I think these achievements would not have been possible. And they help and support us in our common goal for the achievement of excellence. Thank you very much.
Okay, well, thank you very much. I'm delighted to have been asked to come and present some of the research that we're doing. I'm a clinician, I'm a respiratory pulmonologist, and my special interest is cystic fibrosis and infections, and I'm director of the adult cystic fibrosis unit. Certainly, I'd like to thank all the support that we've had over the years, and I think we're really making a massive difference. So what I thought I'd initially talk about is, what is cystic fibrosis? We hear about it on the news. Cystic fibrosis is a genetic disease. It is what we call autosomal recessive, which means you have to get a gene from mum and dad. Now, 1 in 25 of us in the UK are carrying this gene, so there must be a reason for that. And around 1 in 2,500 live births will have cystic fibrosis. So what happens is that the gene has an abnormal code. It's on the chromosome 7. It produces messenger RNA, which also has the wrong code. And the messenger RNA goes to the ribosome, which is a little bit like a sewing machine, and starts producing proteins. And in cystic fibrosis, what happens here is it either doesn't produce any protein or it produces defective protein. So our engineering of our lungs is really quite incredible. What we have is a very important mucociliary clearance mechanism. So if you can imagine inside the lungs, you have got these fine hairs, and these fine hairs are under airway surface liquid, which is liquid, and on top of that you have the mucus, the mucin. And so what's happening here is these fine hairs, a little bit like an escalator. If this is your mouth, what happens is that particles come in and then basically are thrown back out across the mucin. So it basically protects your lungs from lung damage. And this is a normal cell, airway epithelial cell. So this is a cell, and you can see the fine hairs. And what the protein codes for in cystic fibrosis, the protein that should be normal is called the cystic fibrosis transmembrane conductance regulator, or what we call CFTR. And this protein has very important functions. It actually regulates the secretion of chloride and bicarbonate. So it's a little bit like regulates the acidity. It also has an important factor that it inhibits the absorption of salt or sodium and water. So if you can imagine, it's a little bit like if you can imagine a swimming pool. In healthy lungs, you've got these fine hairs beating under a clear blue water of a full swimming pool. The problem is in cystic fibrosis, the gene is so abnormal, so you get bad messenger RNA, so you either get the production or the absence of CFTR. So because you don't have this protein, what happens is that you basically take the brakes off the sodium, you get lots of sodium being absorbed, you get water being absorbed, and you get this dehydration of the airway surface liquid. And so the fine hairs can no longer work, the escalator's wrong. But not only that, it's a little bit like a swimming pool that's half full, but unfortunately it's gone green because the pH is all changed, and this has a significant impact on the immune system. Now, cystic fibrosis is a multi-system disease. And you may think that it's something that you haven't seen before, but actually some of the mechanisms are very important to other diseases. So for instance, we heard about JAK and we heard about muscular dystrophy. Well, actually, some of the genetic defects in cystic fibrosis are caused in a very similar way of abnormal reading of the messenger RNA. And there are going to be drugs in cystic fibrosis that will actually potentially affect and be able to treat this muscular dystrophy. We've heard about cancer. Bowel cancer significantly increased in cystic fibrosis, so understanding the mechanism in CF would also help us understand those pathophysiological mechanisms. So what we really need to do in cystic fibrosis is we need to stop this nice normal chest x-ray turning into this horrendous x-ray where you've got these large cavities and scarring. And in the past, we've always thought that this is due to infection. And so what we've done is we've given antibiotics, and despite this, the median age of death for cystic fibrosis is presently 31. And I think one of the things that we never could understand until very recently is that inflammation is also a key part. So here you can see this is a marker of inflammation. This is a patient with cystic fibrosis going back to 2007. And what you can see here is this C-reactive protein is a reflection not just of infection, but also inflammation. And you can see it's very, very high. And we're only starting to get improvement here as we actually try and correct the actual abnormality, which is the CFTR. Again, on this is a PET scan. This is often used to look for cancer, but here what we're looking for is we're looking for infection and inflammation. And you can understand that this has got very significant hotspots, which are red. Now, we were able, because we had developed electronic care records and graphical interfaces, to start seeing disease patterns. And it became clear that there was a real problem with inflammation in this disease. So we decided we were going to find out why. And here you've got a classical picture of cystic fibrosis in all textbooks. But the thing that's always missing from these textbooks is the white cells. And in fact, our work has shown that the white cells are hyperinflammatory in cystic fibrosis, as are our lung cells. So the lungs actually are very important in defending our lungs immunologically. And one of the mechanisms that we've been working on, and this is a collaboration with the departments of rheumatology, immunology, as well as other centres in Melbourne, other parts of the world, we found that the NLRP3 inflammasome, which is a natural protective mechanism, is hyperactive in cystic fibrosis. So for instance, if you get a bug like Pseudomonas, it comes along, it'll trigger off your inflammasome, and it causes the secretion of these cytokines, IL-18 and IL-1 beta. And these are little messengers that sort of regulate really inflammation and infection. They will basically fight infection. And so you can understand that normally you get a response and then it becomes quiescent, but in cystic fibrosis, you get a hyper-responsiveness. And one way to describe it is that basically I don't have cystic fibrosis. I get what we call the EOR response, in the sense that I'll have a mild response. I will fight off the infection and then respond. Unfortunately, in cystic fibrosis, what we find in the white cells and also the airway epithelial cells, you get this hyperinflammatory response, or the Trigger response, which is causing collateral damage. And it's something we've never been treating properly. So what have we done? So this is a normal healthy cells, and you can see you've got mucin, you've got nice airway surface liquid, you've got the CFTR channel that's pumping the bicarb and regulating the pH of the swimming pool, and you've also got the sodium being reabsorbed. Here what we've got is, unfortunately, the CFTR is no longer present, so you've got this pump that's working 2 to 3-fold at a faster rate, and you're getting airway surface dehydration, and actually the whole system is basically breaking down. But it's not actually that simple. That's what we've always been told. But actually in Leeds, what we've shown is that what's happening is there's a massive increase in inflammation. And this inflammation is causing a lot of damage in terms of the lungs and destruction of the lungs. We also have found that actually within the cells, there's a whole series of processes that are abnormal, including mitochondrial function. So actually what happens is a lot of CF patients will lose lots of weight. And partly this is due to the fact that they are hypermetabolic. So what we did do is there are new therapies coming through called the catheter therapies, and there's a whole series of these drugs. And the way these work is they basically increase the function of that key protein, that little protein that's wrong, that pump, CFTR. And what we found, surprisingly for the first time, was that if you actually give individuals and correct the CFTR, what you find is that at the beginning, your very high levels of these chemicals, these cytokines, this hyperinflammation is reduced over 3 months. If you look at the second line, here you can see the cells. If you try and stimulate cells, and this is both white cells as well as lung cells, you get a hyper-responsiveness at the beginning, which is very, very high. And then as you go for 3 months, it gradually gets less and less. So we are able, with these drugs, to a certain extent, to reduce the Tigger effect to the Eeyore effect, which is really, really important. But what we found is there's differences between people and there's differences between drugs, which have never been identified before. And this made us actually switch all our patients from one drug, Orkambi, to Symkevi very early on, because it was much more effective. And the only way you could show it was by our research. We've also shown that the sodium channel that we mentioned, that is actually one of the mechanisms that's driving inflammation in cystic fibrosis. And we've shown that drugs that block that, which are available commercially, can actually reduce inflammation in cystic fibrosis. Now, obviously, COVID's hit us, and I'm delighted to say that we've managed to continue all our services in a very effective way using modern technology. But COVID is fascinating because you would have thought that, as I've shown you, this hyperinflammation in cystic fibrosis would be devastating with COVID, because you've got quite similarities. In COVID, you've got the production of these chemicals, these cytokines. You get this sort of massive increase in cytokines. But actually what we found is that individuals with cystic fibrosis that have caught COVID have done relatively well. So far in the UK, there are 171 people who have had COVID and only one has died. And we see very similar results in America and the rest of Europe. And this is one of the papers we put forward as a hypothesis, is that it's really important to understand the mechanisms in cystic fibrosis, because this might explain some of the ways we potentially could treat COVID. And one of our hypotheses is that cystic fibrosis, the dysfunction in the cells, actually is the reason why COVID doesn't cause the severe infection. But also we think that the CFTR modulators, these new drugs, have the potential to actually treat COVID. And this is something that the Canadians have started to agree with our hypothesis. So in conclusion, we are the first, with all your support, to actually show that these new therapies actually are very powerful anti-inflammatories. And we're actually on the process of looking at the very new one to see, can we get it back to normal? Do we need to do other drugs to get inflammation back to normal? We also know for the first time that sodium transport is important, and people have been doing trials, but they've been measuring the wrong thing. They've been measuring lung function, not inflammation. So that's really exciting. We think that this work's going to really have a contribute to clinical improvement. And we believe that despite the diagnosis and discovery of the gene for cystic fibrosis in 1989, we believe within the next 10 years, we will be able to cure cystic fibrosis. Will correcting CFTR in airways be enough? And not only that, is it possible that correcting CFTR in carriers or people with other diseases such as bronchiectasis could improve overall outcome? Does inflammation start at birth? And we're exploring this and seeing what happens in terms of age. And could CFTR modulators work in COVID? We're also exploring the potential mechanisms that might be increasing bowel cancer in cystic fibrosis, which may well be related to inflammation. So I think I'll leave it there. I hope you understood some of what I've said, and I'd just like to thank all the funders, because I think we're doing some really exciting translational research which has dramatically improved the quality of care our patients receive.
Thank you. So my name's Rachel and I'm a dentist by background, and I'm currently on an NIHR doctoral fellowship, which means that I've got 3 years to work on my PhD project, which is trying to improve the way we make facial prostheses for patients who have missing facial parts. So during this quick talk, I'll cover my project, why I wanted to work in Leeds, why charitable support has been very vital to the project, and also look at what success would look like in the future. So you may know that head and neck cancer is quite a common cancer in the UK, and around 12,000 people are diagnosed with the condition each year. It's been suggested that about half of people go on to have some form of major surgery. And for some patients, that might mean having a facial part removed. And as you can imagine, this would have a huge impact in their quality of life. The standard way that we rehabilitate people who are missing a facial part is to provide them with a removable facial prosthesis that they'll wear during the day and then remove at night time. The standard way that we make these prostheses has pretty much unchanged in decades, although there have been some innovations recently. So the standard way is to take a mold of the facial part, to hand pour a model and handcraft a wax pattern, to turn that pattern into silicone, and then to hand finish and hand paint the prosthesis. But there are lots of limitations to this process. Patients find the impression or the mold quite claustrophobic and uncomfortable. The whole process is very labour intensive. Outcomes are very dependent upon the clinician's skills, and they have to be replaced, these prostheses, every 6 to 18 months. So patients will come back time and time again. We did a lot of work with our patient and public involvement team in Leeds, and they told us the 3 key areas that they wanted us to improve. So first, to try and get rid of that uncomfortable facial impression. Second, to improve their appearance, to make their prosthesis look a bit closer to the way they did before their surgery. And third, to try and speed up that process so they got their prosthesis quicker, so they could return to work and socialising much quicker after their surgery. So this leads on to my PhD, which is aiming to try and improve the way we make facial prostheses using more innovative digital technology. And there are 3 stages to this digital workflow. So the first step would be to scan patients rather than taking molds of the facial defect, because this would be much more comfortable and potentially a lot more accurate too. The second step would be to design the prostheses based on some quite innovative technology, whereby we can scan in photographs of people from before their surgery and try and recreate the missing facial part based on photographs from social media and various other places. And then the third step would be to try and use computer printing technology in order to speed up the process for making prostheses. So my project has 3 key steps. The first step, the systematic review, has been completed, and it's going to be published in the coming year. The next step, which we're currently working on, is some evaluation of the digital workflow in the lab before we introduce it with patients. And then the third step, which will happen later on this year, is to plan a small-scale trial with a small number of people with facial defects and to test the technology and compare it to conventional techniques. So I have been in Leeds for a number of years now, and I really wanted to stay here for my PhD because it's got a really good specialist head and neck cancer unit. It has really great research facilities, and a whole part of the Leeds Dental Institute is dedicated to research. And we have a really strong and research active digital dentistry team. We've also built links with the Health Economics Department at the School of Medicine, and there's also lots of connections with industry and other NHS trusts, including Leeds Teaching Hospitals Trust, that are going to make the research possible. I'm also really well supported by 4 key supervisors, all of whom are based at the Leeds University of Leeds and Leeds Dental Institute. And these include experts in clinical trials, in digital dentistry and health economics, which are really making the project possible. Charitable funding has been really vital to the project, and it's meant that we've been able to work on some really important locally led and patient-driven projects, but also meet a number of national priorities as well. So there's a lot of information out there now about facial equality. There's lots of national priorities in terms of head and neck cancer outcomes and the use of digital technology in healthcare. The funding from Leeds Hospitals Charity has also allowed us to purchase some really essential equipment that are really essential to my project, but can also be used in future projects within the University of Leeds and Leeds Teaching Hospitals Trust. The Leeds Teaching Hospitals are also trying to develop this really innovative hospital-wide digital laboratory service so that we can do introduce digital technologies into dental care, but also wider medical specialties too. So success for this project in terms of patient outcomes would be to try and improve their quality of life through quicker processes and potentially more effective outcomes. In terms of knowledge, we're keen for this technology to be used in clinical practice, and we would hope that this technology would be adopted in those local trusts that are getting involved in the project soon after completion. From a healthcare perspective, we want to improve outcomes for patients, but we also want to try and get some evidence to say whether this is also cost effective for us to introduce for our services. We've also got a number of collaborations from this project, and we'd hope that we'd be able to go on after this PhD to do a large-scale clinical trial. And then from a personal perspective, it's allowing me to complete a PhD and hopefully have a long-term career as a clinical academic. So I'd just like to say thank you for everyone for listening today, but also a huge thank you for all the funders and supporters that have helped to make this project possible.
Thank you, Rachel, and thank you to all our speakers today. I've found it very informative. I hope everyone else has. I think one of the key messages that we want to get across is that research doesn't happen without funding. It's not something that's funded by the NHS. So when people donate to Leeds Hospitals Charity, it means that we can say yes to the applications that come in. When somebody applies for funding, we go through a rigorous process where we get peer reviews to check that the research that's being done is needed and credible. So the money that is donated is really well spent. And you've heard today from some of the amazing things that have been funded in Leeds teaching hospitals. And often any delays in progressing with research are down to waiting to see if we can get funding for things. I mean, you heard Professor Daniel Packham talking about, the real, very real possibility of finding a cure for CF within what's quite a short time span, 10 years. But that will rely on being able to achieve additional funding to be able to continue with research. So really want to say a massive thank you to everybody who has supported some of these projects and other projects across Leeds teaching hospitals. Donations towards research do have a phenomenal impact. And I'd really like to see if anyone's got any questions, either for myself or any of the people that have spoken today. I believe you can use, so you can see Edward as Edward Ziff, who's our chair of the charity, has posted a thank you to everybody, which hopefully you can all read. If anybody else wants to post in the chat or in the Q&A, or if you put your hand up, we can switch your mic on so that you can ask questions directly.
And we've got a question from Sarah. For Daniel, which is, what would Daniel need to be able to get that cure in 10 years?
I think what's been fantastic in the field of cystic fibrosis is that really many years ago or several decades ago, we really got into international collaboration. And I think what's important is that every project that's happening, so for instance, it needs inflammation, understanding inflammation, which will probably be related also to bowel cancers, all these sort of things, is going to be fundamental to a better treatment for cystic fibrosis. And so what's important is that really research has to happen at an international level with the best of the best. And what's fantastic by the support we've had is that we are doing some research with Switzerland, Australia, Cambridge, so right across the United Kingdom, as well as also United States. And I think the way we're going to get this cure is all working together, and each little project, each translational project is going to feed in. But what's also important is not just going to feed in for cystic fibrosis, because I think what we heard right at the beginning is that good quality research also has a massive impact on the quality of care that we provide and how modern we are. So I think it's just each project links into each other, working together, we will get it better. We've already got amazing improvement with a new drug called Kaftria, which has been approved by the NHS, which actually switches back on some of these CFTR pumps. But what we don't know is how this new drug actually affects the cellular functions. And that's what we're going to be doing in Leeds, to find out, to see whether we need to use other drugs to maximize the benefit and thereby get the eventual cure. I hope that answers it.
Thank you. That's very interesting. And, it just makes you realise what is possible, and the fact that it's actually benefiting patients now, because the clinical trials mean that it's having a direct impact on patients immediately, which is fantastic. So there's another message in the chat from Peter McWilliam, who's one of our trustees, to say, great to see funded projects brought to life through these presentations, which I would agree with. It really helps to understand the phenomenal impact when you donate to Leeds Hospitals Charity, how that translates then into practice. Thank you, everybody. If there's no further questions, then we'll finish there. Apologies for overrunning slightly. Really appreciate your staying to listen, and as I say, we'll be in touch and let you know when our next seminar is, and we will also be sharing the recording with you. So if you think there's somebody else who may be interested in watching it, then you can share it with them. Thank you very much.